Well, hello, everyone. I think we are good to begin. My name is Rose Zacharias. I am the president at the Ontario Medical Association, and I just want to thank everyone, excuse me, for joining today's media briefing on another important healthcare issue. We have been doing these for some time, and thank you for responding positively to the invitation to join us. And we are glad to be in this virtual space together over this next hour. So as I said, I'm Dr. Rose Zacharias, president at the Ontario Medical Association, which represents more than 43,000 physicians in Ontario. Ontario's healthcare system is under immense strain as we continue to cope with the COVID-19 pandemic. As you have undoubtedly heard, and some of you may have written about, record numbers of patients sought care in emergency departments this summer, some of which our emergency departments had to close on nights, on weekends, due to staffing issues, while the backlog of medical services and surgeries continues to grow. And also, we know that we have too many Ontarians without a family doctor. So fixing Ontario's healthcare system will not be quick. It will not be easy. It will require collaboration among physicians, among other healthcare workers, and all levels of government and other stakeholders. And it is this collaboration we look forward to. The OMA has a comprehensive plan for how to do this over the next 4 years, called the Prescription for Ontario, Doctor's 5-point plan for better care. But there are some things that we can start doing right now, and that will make a difference. We're here today to outline 3 solutions specifically that we have shared with the government to address health human resources, to address wait times, and to address the need for more palliative care. First, we need to make sure that we have the right number of doctors in the right places. We support the government's instruction to the College of Physicians and Surgeons of Ontario to give 3-month licenses to physicians from other provinces. But there is more that we can do. We already have mechanisms for licensing US trained family physicians and specialists who want to come and work in Canada, and family physicians educated in countries such as Ireland, Britain, New Zealand, and Australia, where the training is similar to ours. But there are many other qualified doctors anxious to practice here. We propose that doctors from other countries who are landed immigrants and have completed the examination program of the Medical Council of Canada be allowed to practice under the supervision of another family doctor for 3 or 4 years. This could also be a solution for Canadian physicians trained overseas who have not completed their residency. These doctors are especially needed as locums, doctors who fill in for other doctors when they're sick or on leave, to staff emergency departments, and to work in underserviced areas of Ontario. Both groups should then be allowed to compete for an expanded number of medical residency spots for internationally educated physicians. We must also reduce the backlog of care built up during the pandemic and deal with wait times, which were an issue even before the pandemic. To do this, the Ontario Medical Association has proposed the creation of integrated ambulatory centers. These publicly funded centers would offer a broad spectrum of day surgeries and procedures. This would free up hospital staff, free up beds, free up the operating rooms to focus on emergency, acute, and complex cases, while relieving strain and capacity issues inside the system. As part of this new model of care, the OMA is ready to work with the government now to develop a centralized referral system so that patients in most need of high demand surgeries and procedures are distributed among all available doctors, regardless of where they live. The third OMA solution is to make palliative care available 24 hours a day, 7 days a week. Of the more than 100,000 people who died in Ontario in 2017-2018, only 61% received palliative care in their final year. Many who lived in the community had to make an unplanned visit to an emergency department during their final month of life. The OMA recommends the government increase the number of hospice beds and provide consistent funding to operate them. Ontario should have about 945 to 1,350 palliative care beds province-wide. However, currently, we only have 271 hospice beds in total. We also need to enhance supports to allow individuals to receive palliative care where they need it, including at home. That means having access to on-call palliative specialists who are available when patients most need them. And we need to integrate palliative care within long-term care homes. We would also like to see more training to increase the number of palliative care health professionals and workers. These solutions would improve both the patient experience and that of the caregivers, and it would be better for the overall healthcare system. Ontario currently spends more than $208 million a year on dying, hospitalized patients who are waiting for a bed in a more appropriate care setting. Ontario's doctors think that this money could be better spent on the beds and resources that these individuals are waiting for. Each of our panelists today is an expert in one of these fields that I am talking about, and we will talk more together about how these solutions could work and why they are so urgently needed. I'd like to introduce our panelists now who are here in the room. First of all, Dr. Joy Hataley. Hi, Joy. Is a family physician and anesthetist and chair of the OMA's District 7, which includes the Kingston area. Welcome, Joy. Dr. Jim Wright is a pediatric orthopedic surgeon and executive vice president, economics, policy, and research here at the OMA. Welcome, Jim. Also, Dr. Sandy Buchman is a palliative care physician and medical doctor of North York General Hospital's Freeman Center for the Advancement of Palliative Care. I am going to hand it over now, first of all, to Dr. Joy Hataley, who's going to talk about doctor shortage specifically. So Dr. Hataley, can you tell us some of the innovative things being done in the Kingston area to attract new physicians? And what is the impact on patients when they don't have a family doctor? And how does that impact the healthcare system overall? I know you have incredible insight into that. So welcome, Joy, and please, your thoughts on these questions.
Thank you. Thank you. You know, I want to start by saying that I appreciate what a critical role each of you in the media play in determining the solutions for our province and the way forward. And that's in filling in the communication gap between those of us who are experts and have the working knowledge of the system and policy and decision makers and the public at large, because I think they play a very important role in moving things forward and making things better. I think we can all agree that we have a crisis. If we look at 2018, we said there were around 1 million people without family physicians in Ontario. In 2020, we know it's closer to 2 million, and we're predicting that in 2025, it will be closer to 3 million. This is untenable given to what happens to patients who do not have a family physician. This happens to them because our healthcare system is structured with family physicians as the natural entry point into healthcare. There are other routes in, but they're not simple for patients and they're costly for our system. So we need to figure out a way to make the system function for everyone, not just for a cohort of people who are assigned or rostered to a family physician. And even for those that are rostered, we can talk about some of the backlogs in the system. That's actually a topic for another today. But you know, despite all of this, I have become extremely optimistic in the last 6 months. I'm optimistic because the important conversations are happening as it is right here today. And I feel that now that we're aware of the extent of the problem, we are motivated to fix it, and we are bringing the right information to the table. When a patient does not have a family physician, they do not have simple, easy, or natural access to care. And I want to tell you about a few patients that I have personally interacted with in the last couple of years who do not have family physicians. The first was the most heartbreaking for me. A 30-something-year-old patient arrived in the emergency department just before Christmas, having been suffering from symptoms for at least 6 months, potentially longer. finally decided to come to the emergency department, hadn't come earlier because this person was a single parent of 3 children. Very busy, working full time, had a lot on the go, but finally could not ignore their symptoms any longer. They had their initial workup in the emergency department, and there were concerning signs immediately. They were referred from the emergency department to specialty care, diagnosed with a serious form of terminal cancer. Still no primary care available for this person. This patient lived out their last months with us providing their primary care in the emergency department. This patient came back several months later to die with us, and we carried this person forward. It's still very emotional for all of us, and you can only imagine the fallout for the patient and the family when many steps along the way they had unscheduled visits to the emergency department to have their care needs met because they didn't have a primary care provider to coordinate all the steps along the way. It was very difficult for us. I'm thinking of another patient in their 20s, a schizophrenic, living in a supported environment. Their family doctor retired. 6 months later, they ran out of refills, didn't know how to get more, went off their medications, arrived in our department psychotic, required sedation, required security, required restraining, required a transfer on a form involuntarily to a psychiatric unit where they remained for 3 weeks to get back on their medication, stabilized, and back to their real life. If that person had had consistent care, none of those things would have happened. And you can see the inherent expense for the system and the unnecessary resources used that could have been avoided had that patient had consistent primary care. The third is a 3-month-old infant who moved to our community recently. Actually, I should tell you, it's a 4-month-old infant in this case. And why that's relevant is this family signed up with Healthcare Connect in our community, as they should, but it's a 4-year wait. If you're a 3-month-old infant, you meet the criteria for fast track to the next available physician. But if you're 4 months old, you don't. And this particular child was 4 months old. And so what's the family to do? How do they get routine immunizations, which come every few months? How do they get monitoring for milestones of development? Where do they go? You can immediately see the problem in not having a primary care physician. Well, in Kingston, several of us became worried about this, many years ago, in 2016 already. And in 2018, a good friend of mine and a colleague and an OMA advocate and the chair of our steering committee, Dr. Veronica Lignini, called me up and said, let's go meet with the mayor. Let's tell him what's happening in family medicine. We already knew many of our colleagues were retiring. Some were leaving medicine for other disciplines. And we met with the mayor, and the mayor validated our concerns. And they had also been hearing at City Hall about the trouble in finding a family physician. It was even affecting our business community and the development of thereof. So City Hall asked us to do a human health resource study, which we did. It took about 1.5 years to do, but we surveyed the family physicians in our community, asking how many patients they had, where they were in their career, when they were planning to retire, were they making any changes in what they were doing currently. And we got the numbers together and we realized that we were shy at least 20 family physicians in our community. And this is 2 years ago. And so we started working together to come up with solutions, and we set up a recruitment program with an incentive to come to our community. And then we invited residents from graduating programs across the province and from our own Queen's University to meet with us. And we had a virtual meeting with the residents, and we outlined our incentive program. And I'm happy to say that last week we announced we have 9 new family physicians in our area. You know, the trouble is that during the time frame that it took to do the study and to get 9 new physicians, we lost 7 to retirement and people quitting medicine for various reasons. So we're net new 2, but we also have 7 practices worth of patients that still have a family doctor. So we're delighted with our success. But you know, this has really made us stop and think about where we go from here. We have more incentives. We can accommodate 11 more doctors on our incentive program. We are in communication with some family physicians from the northern states. But, you know, we've really talked about what happens if everyone in the province sets up an incentive program like this. Are we not just competing for the same pool of physicians? And we already know we don't have enough. Even with the current graduating classes, we do not have enough. And so it becomes an ethical issue. How do we recruit going forward? And I just love what Dr. Zacharias has presented today, to look to outside jurisdictions to bring doctors in. It is actually the fastest route to filling the niche. And then we don't compete with one another. And our mayor, Mayor Patterson, when he announced the 9 new physicians, he actually called on other levels of government to band together with us and to help us bring physicians to our community. And I think that's what we really need to see. We need to see all levels of government coming together and figuring out how we bring net new physicians out of our own jurisdiction, not gaming from one another, but out of our jurisdiction to our province. And, you know, we know that 4 million people have left the Ukraine. They've already left. You know, we wouldn't be inviting people who are actively serving a war-torn country in the Ukraine. They've left. Many of those people are healthcare workers that have skills. You know, can we figure out a route to inviting those people with the skill sets that we need here in Ontario? Can we find a route to bringing them here? And similarly with several other cohorts, you know, where should we be looking for the resources that we need and that we need now? We don't have 1 or 2 decades to produce them on our own. We need to bring in other people. Thank you.
Thank you so much, Dr. Hataley. I really appreciate, of course, the compassionate care that you're delivering there in the Kingston area, but also, I mean, inside the healthcare system crisis, we talk about numbers, alarming statistics, but it's really important for us to hear the stories. And so thank you for the care you're delivering. Thank you for sharing stories with us. We are going to move on. Dr. Jim Wright, as I said, is our Vice President, Economics, Policy, and Research. And Dr. Wright, please, can you speak about the integrated ambulatory centers and how specifically they will help with the reduction of wait times? Jim?
So I'm going to start with the experience worldwide that ambulatory surgery and procedures can be delivered 25%, approximately 25% more efficiently, including that's Canadian experience. What does that mean? That means for the same amount of money, you can do 25% more. Or for the same amount of procedures, you can do it 25% cheaper. So that's the fundamental rationale. And the Auditor General recognized that we lag behind many other jurisdictions, including other provinces, in implementing this mode of delivery. So the key components of the integrated ambulatory clinic are threefold. First, that it be partnered with the acute care institutions, the regional planning, and ultimately the Ontario Health Team. So it's part of a comprehensive plan. How do we deliver surgical and procedural care to make sure the patient receives the right care in the right place? The second is this phenomenon of skimming. We want to ensure that whatever the funding mechanism, that it's appropriate so that you don't have low acuity, high remuneration cases going to these ambulatory centers and disadvantaging the acute care institutions. And that's part of the planning and the partnership. And the third is we have some ideas about enhancing the current quality structure to ensure, irrespective of where the patient receives their care, they receive the highest quality care. So the first step is obviously to invest in what our current structure is. The government has invested and is doing its best. But the next step is to introduce new legislation that will allow us to reform the system and expand this opportunity for patients across Ontario. I'll stop there and wait for the rest in the question period. Thanks, Rose.
Thank you so much, Dr. Wright. Really appreciate that. And we will come back to you in the Q&A. Dr. Buchman, to speak specifically about how palliative care can be delivered differently and more abundantly in order to meet the needs of our patients. Please, Dr. Buchman, go ahead.
Well, thank you, Dr. Zacharias, and to everyone for the opportunity to speak to you today about how palliative care can be part of the solution that's facing the backlogs in our healthcare systems, in our emergency rooms, and in our acute care settings. I think palliative care can really make a difference. And the solutions that solutions that I'm going to propose are actually part of the OMA 5-point plan to be referred to, because they had input, and we've been talking about this for a long, long time, pre-pandemic, might I add, and it's only gotten worse, of course, during the crisis. So one of the issues is, how can we improve palliative care in community settings so that it kind of takes the pressure off our acute care hospitals? And palliative care can be delivered very effectively in the community. My best estimates are that 70% can actually be delivered within a primary care setting, with palliative care specialists and teams backing up primary healthcare teams. So, as to Dr. Hataley's point earlier about the importance of family physicians, and might I add, health human resource planning in general. I'll give you an example. I'm the medical director of the Freeman program in North York. Our Ontario health team, the North York Toronto Health Partners, serves over 500,000 people, but within the urban, highly urban and dense area of North York, we have about 1 million people. We do not have one hospice residence within North York. As a matter of fact, in the city of Toronto, there is only actually one adult hospice residence at Kingston Health. There is a hospice where I worked very effectively for people experiencing homelessness. And there's Casey House for dealing with people with HIV/AIDS. But otherwise, there's no other hospice residence where people can go for cost-effective end-of-life care. As an example, the last data that we have was from the Auditor General's report of December of 2014. So we can just scale it up. But at that time, it cost it cost the hospital $1,100 a day to keep that patient in hospital. In a hospice resident, it costs $450 a day. About 70,000 people die in hospitals a year. And say we took half that, 35,000 that could be looked after in community, say in a hospice setting. We would be saving, what, $550 a day, I think, per patient. Average length of stay, 21 days, times whatever tens of thousands you want to do. This works out to hundreds of millions. Yet I decided with a group of concerned citizens to build a hospice in North York. We started about 6 years ago. We've had a vigorous campaign. We've raised $18 million. And now with inflation, it looks like we're going to have to raise another 9-10 million. We have land in North York. We have our permits. We're kind of ready to go. The government of Ontario, through a lot of advocacy, is giving us $200,000 per bed. For a 10-bed hospice, it's $2 million. Why, for essential healthcare like this, must it be so charitable? In other words, why there's no planning, nothing. So we're advocating for a whole network of hospice and end-of-life care that can be very cost-effective and give the quality of care that patients need. In addition, in my large area of North York, we have no palliative care unit. So they are usually within the institutions, and they, as opposed to hospice, which is more home-like, but they also provide end-of-life care and interventional symptom management that can really help people during this phase of life. We also believe that we should really be enhancing the palliative care services and supports at home. Right now, we have a series of interprofessional teams, but it's inequitable across the province. It's really important to get those services everywhere in the province. And we're having shortages in the community too. I had a recent case of a patient at end of life. The system will promise them, the family who was struggling to take care of their elderly parent, at 56 hours a week. We could not find a personal support worker or other support for this patient, and the family was difficult. We did everything we could to keep these family going so that the patient could remain at home in the care of her loving family. Another major solution is about our long-term care. We saw the tragedy of the pandemic in long-term care. And the number of people that were lost. We see these patients, sadly, showing up in emergency rooms and then getting admitted to hospital for long-term care because there may not be another place for them. We're advocating for increased supports of our elderly and senior patients in the community through a couple of mechanisms. team-based care in the community. We have one at North York General called the Leong Geriatric Program, where we provide supportive care to patients with non-malignant disease in the larger community. We support their primary care team. We have huge and fantastic numbers that show how we prevent emergency room visits and we prevent hospital admissions because we have these conversations. What are their goals of care? What do they want? Are they oriented towards comfort care? Integrating a palliative care approach into our long-term care facilities can make a huge difference in caring for patients, comfort-oriented care in their home, and preventing these patients showing up in emerge and then ending up as alternative level of care. And finally, again, palliative care is a great example of interprofessional care. Nurse practitioners, nurses, personal support workers, social workers, physicians, we all work together in the community, and we have no sort of planning for this. We have no health human resource planning in the region, in the province, frankly, in the country, and we have to do much better at thinking about our health human resource needs, particularly in RA and palliative care. So thank you for the opportunity to speak to this.
Thank you, Dr. Buchman, very much. And so we have come now to the question and answer period, and we really do want to get your questions answered. I know many of your questions have already been answered or entered into the chat, and Emily English from the OMA will be moderating our question and answer time. If we don't get to your questions, the media team will follow up with you. You can also email, and we'll put this in the chat, media@oma.org with additional requests for interviews today after the media briefing. And also to remind everyone that there will be a recording of this session available later on this afternoon. And so, Emily, over to you, and we'll get right to the questions.
Thank you, Dr. Zacharias, and thank you to all our panelists for your time today. The first question is for Dr. Jim Wright, and it's about integrated ambulatory centers. Dr. Wright, could you tell us how the patient experience would differ for surgery procedure done at an integrated ambulatory center versus at a hospital?
Yes, thanks, Emily. And I neglected to point out our preferred route for integrated ambulatory centers is publicly funded, not-for-profit, OHIP supported. So I think that's an important point that likely will come up in subsequent questions. But to answer your question about the patient experience, if any of you have entered a hospital, it is a complex place to get into. There are so many things going on in a hospital, and ambulatory centers would be a focus on the very narrow range of what they deliver. So the experience for the patient would likely be on their day of procedure or surgery is a rapid pathway through an ambulatory center. So their surgical procedural time would be less. They would be in and out faster in an easier way. But I also want to emphasize one of the dilemmas. So I was surgeon in chief at Sick Kids for 10 years. And one of my dilemmas is I had 3 streams of patients. I had inpatient, outpatient, and emergency. And unfortunately, that meant many patients were canceled even the day of their procedure. That's very unlikely to happen in an ambulatory center, which is focused purely on those patients receiving their procedure or treatment that day. So I think there are 2 facets of this, but the experience worldwide is patients like it, the recovery is faster, and they're through, and they find it a much more streamlined experience. So it's not just efficiency, quality, but it's also patient experience.
Thank you very much. And we have another question on the proposal for IACs. This one comes from Joanne Lashes with the Ottawa Citizen. So again, Dr. Wright, can you explain a little more about how referral centers managed by the province would work? How far would patients be expected to travel? And also what kinds of conditions would be treated at an integrated ambulatory center?
Thank you for raising that. There is long-standing relationships between family physicians and specialists, and we wouldn't want to interfere with that. However, in many circumstances, family physicians struggle to find the right specialist in an appropriate time frame. So what we imagine is if you would regionally begin to say, okay, if a family physician wasn't sure who to send to, or their preferred person wouldn't be able to see them in an appropriate time frame, they would be able to use this centralized referral system. But let me emphasize, patients come to centralized referral. Some want the shortest wait, in which case they're willing to travel. Some want to stay close to home and they're willing to accept a longer wait. Some want a specific physician or center and are willing to accept the distance and the time. So patient preferences would be critical to matching both the best supply with the patient's preferences. So it doesn't mean you have to travel, but you could choose to if you said, I want the shortest wait and I'm willing to go to Thunder Bay to get it. Thanks very much.
Thank you. And the next question is for Dr. Sandy Buchman. Can you explain more about how increasing access to palliative care would ease the burden on the healthcare system overall, and particularly on emergency departments?
Yes, thanks for the question. So it goes back to the increasing community supports that we need to provide palliative care and a palliative care approach. So discussion about what a patient's goals are, really understanding, say, the benefits versus the risks of aggressive care when people are living with life-limiting disease. So if we increased our supports in the community in several ways, things I referred to earlier, the building of more hospice residences and hospice beds across the province, the establishment of more community-based teams that can serve patients and provide, as Dr. Zacharias said earlier, 24/7 care. This would go by integrating the approach that we're taking to having these conversations in long-term care, by training more professionals of all backgrounds to provide comfort-oriented quality care. By doing all these things, we will be able to reduce emergency room visits and hence hospital admissions. People will get appropriate care and care of their choosing. The vast majority of people, when you bring this up, actually do not necessarily want the aggressive care when they see the whole picture. They're looking for quality of life. They're looking for time and comfort with their families and not spending time in an intensive care unit or a acute care bed in a hospital. So by improving these community-based supports, by integrating the approach in long-term care, providing funding for more beds, we can create a system that will really move a lot of these patients who, after their acute care needs are met, don't really need to be in hospital anymore. We'll free up the beds that we currently have in a much more cost-effective way than we do now.
Thank you very much for that answer. The next question is for Dr. Zacharias. How quickly could these three solutions the OMA is proposing, how quickly could they be moved on?
So we are calling on these solutions to be moved on now. This is the time. We have had gaps in the healthcare system prior to the pandemic. The pandemic and the strain on the healthcare system is obvious to all of us. I've worked in an emergency department for 20 years. I actually couldn't have imagined the day when we would be closing emergency departments. This just seems wrong in our province. And so we need to act on these solutions now. These are extremely vital areas. All the things that we've been speaking about today, to reduce the backlog, to catch up on the wait times, to invest in our community and home care, as Dr. Buchman has been clearly outlining. And ideally, everyone in Ontario should have a family doctor, and not just a family doctor, but a team of healthcare providers connected digitally so that the system can talk to each other, and physicians can come away from even the administrative burden that's on a lot of physicians and have them back in relationship with patients, delivering patient care directly. A statistic that is just alarming to me is for every 1 hour of direct patient care that a doctor provides, they spend 2 hours documenting the visit. This is also something that needs to be addressed. But when we are outlining these solutions as we have today, we are saying they can be implemented now.
Thank you very much for that answer. And the next question is for Dr. Hataley. if more internationally trained doctors were allowed to practice in Ontario, how would that affect a community like Kingston that has thousands of patients without a family doctor?
I think it's a win-win, internationally trained doctors, other countries recognize that Canada is a wonderful place to live. There are still a lot of freedoms, a lot of choice, opportunity to develop your talents and your skills. So many physicians want to come to our country, and we need more physicians. And there's several communities, as Dr. Zacharias pointed out, several other international or other countries who train their physicians in a very similar manner to what we do, have a very similar approach to care provision, and it would be quite natural to integrate those physicians into our system. There's lots of mentorship available. Physicians who are on the ground now working recognize the issues. We want help, we want support, we want to share the workload. We're happy to bring in internationally trained physicians and mentor, work alongside them, work with them, help them understand the nuances of our system and how we best take care of patients, understand where the resources are that they are going to refer patients to and that they're going to draw on to give our patients, our fellow citizens care. So I think we're ready to bring on physicians from other jurisdictions. We just need to find them and we need to attract them to our communities.
Thank you very much. And I see Dr. Jim Wright has raised his hand, so please go ahead.
Yeah, I wanted to emphasize that the pool of physicians that we see as most eligible are already landed immigrants. They've already made the move to this country. And the second thing is many of those physicians, if not all of them, would likely spend their early part of their career in what we call underserviced areas. That is those areas which lack physicians, particularly family physicians. And unfortunately, that is in many cases largely the North. So this return of service obligation comes with the ability to work in Canada. So, and that might be Kingston. It doesn't mean to say it couldn't be Kingston. It's wherever they're most needed. So as we think about this, it's putting all of those pieces together, both bringing them into the healthcare system, but also making sure that their efforts are where they're most needed.
Thank you. And we have a follow-up question from Joanne Locious at the Ottawa Citizen. This one is for Dr. Wright. What kinds of conditions can be treated at the ambulatory center? Is it things like hip and knee replacements? And can you tell us about a jurisdiction where this has been successful?
Sure. So I'll answer the second part first. Saskatchewan has done the greatest, and that's where our estimates of efficiency come from in a Canadian context. But I would say that it's a worldwide experience around the efficiency. So I would say that the kinds of procedures is becoming a daily expansion. So certainly when I started as an orthopedic surgeon, you would never have conceived of doing a joint replacement in an ambulatory setting. But what we've learned is with the right patient and the right procedure, they can be delivered in ambulatory setting with similar or better quality. So I need to emphasize it's both the patient, because you may have a very simple procedure, but the patient has a lot of complexity. They belong in an acute care institution. Or you may have a healthy patient with a slightly more complex procedure, but still can be done. So the list is getting bigger and bigger every day. So if we can deliver a broader range of procedures safely with better efficiency out of an acute care institution, that's what we should be doing.
Thank you. And the next question I'll direct to OMA President Dr. Zacharias. This one comes from Len Gillis at Sudbury.com. Can the OMA comment on Bill 7, the idea to have ALC patients move from hospitals into long-term care homes? Sometimes that could be a significant distance away from family members. This move might free up hospital beds, but could it create more significant problems for ALC patients?
Thank you for the question. We, as Ontario's physicians, understand and appreciate that in times of healthcare system crisis, difficult decisions are required and will be made. At the same time, we hope that these regulations would be implemented with flexibility, with compassion, with an understanding that patients do better when they are surrounded by their loved ones and caregivers, and when accommodations are made for the language they speak, the cultural background, their faith perspective, and all of the aspects of their well-being are provided for. And so as we move forward and in this stage of our pandemic, we do want our healthcare system to become robust and thriving, and yet at this time that is not our experience. These are difficult decisions, and we will always advocate for the very best well-being of our patients as decisions like this are being made.
Thank you. And lots of questions today on the IACs. This one comes from Mike Crawley with the CBC. It's for Dr. Wright. What would the relationship be between hospitals and the integrated ambulatory clinics? Would hospitals manage them, or would they be independent? And if these clinics could just do day surgeries, how would that actually help reduce the inpatient burden on hospitals?
So I think there were 3 questions there. So how do they help? Well, you shift the patient out of the acute care institution, allowing them to focus on the most seriously ill. So that's what hospitals are best at. What does the partnership look like? Well, it means that there's a discussion about what is the right place for the right patient. The doctors would probably, we would see ideally, be credentialed in both places so that they would have experiences and potentially be able to look after their patients in both facilities. Occasionally, there are patients who come out of an ambulatory center, an integrated center, who might need to stay overnight. Well, then you need to have that relationship with the hospital. So that's not showing up in the emergency department. Part of the planning that goes into the relationship between the hospitals. So it's a complex relationship, but that's why we call this integrated rather than independent, because we want to see all of those issues resolved between the hospital and the integrated center. So the patient has the confidence that there's a system around them rather than working independently.
Thank you very much for that answer. The next question is for Dr. Sandy Buchman. You're working on getting a hospice built in North York. Can you explain more why expanding hospice care in Ontario is necessary?
It's a great question. And I'll share a couple of reasons I can think of right away. First of all, many people are not able to care for their loved ones at home, either because of their own illness or infirmity. Elderly people, for example, may be widowed or have no one else. They need a place where they can receive appropriate high quality care around the clock. Hospice environment is a home-like environment, and it provides that kind of comfort, addresses all their needs. If their spouse is ill or suffers with serious health problems, it's very, very difficult to look after a patient at end of life alone at home, even with lots of community supports. Secondly, as I referred to earlier, hospice beds are very cost effective. So people are getting the high quality care that they need and freeing up acute care for the people that are ill and really need that kind of care. So you have a specialized team that is very experienced and focused on delivering end of life care. We also need, of course, the palliative care unit beds, which are some end of life, but also for interventional pain and symptom management. Many people need the investigation ability or the interprofessional approach. We may need anesthetist, for example, to do appropriate pain management in a palliative care unit setting. So that's a little bit of a different kind of care, but along the continuum. So for those are some of the main reasons why we should be encouraging the development of hospice and palliative care unit beds in the province.
Thank you very much. We have a question from Megan Ogilvie from the Toronto Star. This is a question for Dr. Wright. Can you please outline a potential timeline for integrated ambulatory centers in Ontario? Is there an indication that the provincial government is considering this new care model? Last month, the provincial government released its plan to stay open, in which it states, "We are exploring opportunities to improve the efficiency of surgical delivery." Does that include, to your knowledge, IACs?
We've had some very positive conversations with several branches of government and with several ministries, all of who are very excited about looking at a new model of ambulatory care and are very keen to achieve integration. As you understand, that's the rationale for Ontario health teams. That's a critical aspect of care, is a system which is integrated. And this model, which we've come forward with, I think addresses many of those issues. So clearly, the government is investing in their existing resources. We would like them to move very quickly on legislation that would allow us to begin to implement this model. We believe it's time to bring together an expert advisory group to help the government in this implementation. We see it as in several phases. Optimistically, this could be 12 to 18 months. We could see the first of these centers start to open. But this is going to require us working together to deal with all these issues. And there are issues, or let me not say issues, there are practical challenges in doing this, a new system, but we believe we can do it together.
Thank you. And this next question is from Marjo John with the Medical Post. I'm going to start with you, Dr. Hataley, but perhaps Dr. Wright, you may have thoughts on this one as well. So beyond the countries mentioned earlier, like US, Australia, New Zealand, what is being done today to identify countries we would consider to have training that aligns with what Canada offers? The UK is proposing to put together a safe list of countries from which to recruit doctors. Is this something that Canada should also be looking at?
I think we should leave no resource untapped. I think there's additional work to be done in those areas that, maybe we want to go for a cast in the pond where we know fish exist, as opposed to go fishing in a pond that we don't know. But I think no resource should be left untapped. So we should certainly explore those things. We have to be a little bit careful. We have to be socially responsible, not only on a provincial and a national level, but on an international level as well, and be sensitive to the needs of other countries that we look at as well. And, I'm not in a position to say where there are an abundance of physicians and where there are not. I think, to Dr. Wright's point, there are people who have physicians who have pre-selected our country. They're already here. They're on the ground. That's probably the first place to go. Let's go to places where maybe we have the least risk of making a negative impact on another jurisdiction. So I would say let's look at who's in our backyard first.
Thank you. And before we move on, Dr. Wright, did you have anything to add to that?
Yes. There are a few countries where we can say with confidence that every graduate has reached a standard of capability and capacity. But I think in other circumstances, we should be focusing not on the country, but on the individual. There are some people who might be trained in countries which are not kind of traditional, let's say UK, Ireland, Australia, and New Zealand, and yet they are fabulous physicians. And we, along with the college, believe that practice-ready assessments, perhaps supervision, would allow the safe introduction of very talented individuals who might come from countries that we don't traditionally think about. So I think the safe country is missing the point. We need to focus on the individual who has the appropriate capability rather than necessarily the country they came from.
Thank you very much. The next question is for Dr. Zacharias. Beyond these three solutions, what other recommendations does the OMA have to improve healthcare?
Thank you. In our 5-point plan, our prescription for Ontario, we outline additional solutions. Today, we haven't talked about mental health and addictions strategies, and we are calling for more investment there. Working in an emergency department, knowing that, I mean, it was 1 in 5 Canadians prior to the pandemic that said they were struggling with anxiety, depression, and the Mental Health Commission of Canada released a study mid-pandemic and said 84% of their respondents said their mental health worsened during the pandemic. And so we know there is a mental health tsunami. We talk about all of these other shortcomings inside our healthcare system, the wait times and the waiting for a surgery or a cancer screening, and being at home needing palliative care and not getting it, or just not having a family doctor. And then you can overlay on top of that a mental health challenge and a state of mind and your well-being that is being impacted profoundly. And so we need to focus on team-based community care around mental health, because coming into an emergency department, coming into an acute care setting where people do come in crisis is not the best place to walk alongside someone when they're struggling from a mental health issue. So that is one. Additionally, we know there's high levels of burnout amongst our healthcare team providers. Ontario's doctors responded to a survey and said almost 75% of us are operating at levels of burnout. And we know that we want doctors to be invigorated and walking into their workplaces and existing inside their practices, not exhausted, not burnt out. And so there are strategies to reduce the administrative burden that is on doctors, that takes them away from direct patient care. When you graduate as a doctor, you intend to build relationships with your patients of trust that will impact their lives profoundly. And yet there's, over the years, so much more that's been expected of doctors that I think takes them away from that direct patient care that contributes to burnout. These are two key areas that I know we need investments in.
Thank you for that answer. And I see Dr. Hataley has her hand raised, so I'll throw it over to you.
Yeah, I want to make sure that we don't miss another point when we're looking at primary care, and that is that we can utilize our healthcare providers better by having each of them work to top a scope. And by that, I mean physicians are doing a number of tasks that they weren't ideally trained to do. Some of that is triaging of patients. Much of it is truly just documentation, just putting the data into the electronic medical record. And team-based care will help us utilize our physicians much better, keep them doing the clinical work that they're so well trained and specifically trained to do, and take them away from some of the tasks that are eating up their time but are not bringing the level of value that we'd like to see from someone trained as a physician. And so I'd like to mention two things today. The first is scribes. I think we need to incorporate scribes into our Canadian healthcare system in a very meaningful way to offload many of those tasks that contribute to burnout and stop our physicians from doing the clinical work that they love to do and that we need them to do. And the second is, I think in teams, we need to incorporate a triaging system. So when you call into a team with a healthcare problem, you shouldn't simply engage a telephone scheduler, but you should talk to an expert in triage who can take the very basic details on your healthcare need and ensure you get an appointment with the right person. And I'm going to use the example of the sprained ankles. I can't tell you how many hours I've spent my tires on directing sprained ankles to a physiotherapist or to another care provider. And if we had knowledgeable triage answering the phone, that never would have come to my attention. It would have gone directly to the physiotherapist, the occupational therapist, someone else, and would have freed up my time to do the clinical work with the more acute patients that I needed to do. So I think we need to utilize the healthcare providers that we do have in a very intentional way and allow them to work to top of scope.
Thank you very much. And the next question we have is for Dr. Buchman. Dr. Buchman, could you explain how increasing palliative care can offer cost savings to the healthcare system?
So yes, again, the data that I can refer to specifically for Ontario comes from the Auditor General's report of December 2014, but we just have to scale it up to inflation. The ratios, et cetera, are the same. When you undertake a palliative care approach, so a discussion with their patient and their families or substance decision makers about what their individual goals are. You have to include not only the evidence for any kind of procedure or therapeutic intervention, but you have to take into account the individual patient's culture, their faith, their values. That's how we make healthcare decisions, by incorporating the evidence for a decision with a person's particular faith, culture, values, and you bring them together. And when you look through that lens, people will often make decisions that will focus on the quality of their life and their care. Again, they may not want to spend time or their days in an intensive care unit, acute care hospital bed, receiving medical interventions that aren't consistent with spending time at home or being with their loved ones and being with their families. So when you do that, you can have treatment in a setting that is much more in line with the patient's wishes and much more appropriate. And you can often provide that at home in a much more cost-effective way, or as I mentioned, in a hospice or palliative care unit, much less expensive than in an acute care setting, and give the patients the value that they want. And the care that's most appropriate for them. So we have a more satisfied patient, more satisfied family. We take the pressure off the acute care system, off the emergency room, and patients are allowed to express their autonomy. And we see the kind of care that is really appropriate for a particular phase of life. And remember, palliative care is not just end-of-life care, but it's an approach to care that can even begin for years. So having these conversations of what their goals are in long-term care, et cetera, will do so much to enhance the quality of the care and relieve the pressure on the healthcare system in a cost-effective way.
Thank you for that answer. And thank you to all the journalists who asked questions in the chat today. We are nearing almost the end of our time. So if we didn't get to your question today, you can email us at media@oma.org and we will follow up with you. We do have one final question before Dr. Zacharias makes some closing remarks. So Dr. Wright, this question's for you. Another question from Megan Ogilvie from the Toronto Star. What's the state of the surgical backlog in Ontario right now? Can you provide some data on the current wait list for scheduled surgeries?
So it's very hard to put an exact number because many of those patients are, for a variety of reasons, have not entered the healthcare system. So we know that the historical numbers were severely dropped during the pandemic. So there were many healthcare interactions that didn't occur. We believe that the majority of those that were surgery and procedures continue to be needed, but they have not made their way back on the waiting list. So it's very hard for us to give that kind of answer. I would tell you that we are seeing, unfortunately, many patients presenting later in the course of their disease. You already heard one of those stories from Joy, and that's a tragic circumstance because many patients will suffer because they're just too far along in whatever the course, or even if we do treat them, they won't have the same expected benefit. So right now, we're seeing the numbers slowly begin to climb, which in many ways is a good thing, but we anticipate it's going to get much, much bigger before we see it leveling off.
Thank you. And Dr. Zacharias, I believe you have some closing remarks.
Thank you, Emily. Thank you for moderating the question and answer time. Thank you, of course, to our guests in the room, Dr. Joy Hataley, Dr. Sandy Buchman, Dr. Jim Wright. Thank you to everyone who's come, given us your undivided attention, and we want you to know that you can continue to reach out for interviews. And I know we've put helpful information in the chat. We really do believe in the urgency of the application and implementation of the very specific recommendations that we have talked about today around the doctor shortage, investment in community care, palliative care, and catching up on the backlog of surgeries and procedures through our integrated ambulatory centers plan. So please continue to reach out. But once again, thank you for your time, and I'd encourage you all to be well. Bye for now.